This is Katie Bodine, and we are going to be discussing facial nerve palsy. The lecture is intended to meet our Level 1 and Level 2 objectives for the DMS program. Historically, Bell palsy was thought to be an idiopathic facial nerve, which is peripheral 7th cranial nerve palsy. However, it's now considered more of a clinical syndrome with its own differential diagnosis. So the term Bell palsy is not always considered synonymous with idiopathic facial nerve palsy, but about 50% of the cases do remain idiopathic. It's also a very commonly used name, despite the change in the thought process behind its classification. So the mechanism of action is that the facial nerve is inflamed due to an immune process or a virus. So the nerve swells, it is compressed as it exits through the labyrinth portion of the facial canal, which results in ischemia of this nerve. The most common viral etiology is herpes simplex virus infection, HSV. This will be seen on board questions. Herpes zoster is the second most common viral etiology, but there are a host of other viruses that commonly predispose people to developing this parasis, as well as other disorders including diabetes, Lyme disease, and sarcoidosis. In fact, people with a history of sarcoidosis may even develop bilateral palsies. Signs and symptoms: pain behind the ear, and that's where the nerve is exiting, and they will then develop complete facial paralysis within hours. So that's really important to remember. That is a very rapid onset. You can imagine this would be difficult to tease out from a stroke if they woke up with this, but if you can tease out preceding virus and pain behind the ears, that might help lead you to this diagnosis. The affected side is going to appear flat. It'll be expressionless. They won't be able to wrinkle their forehead entirely, so you'll notice the affected side having some flattening, maybe of their wrinkle lines. They might have a widening of the opening between the eyelids, or inability to fully close that eyelid, which is important to note, and flattening of the nasal labial fold, and perhaps drooping of the corner of the mouth. Because of that, they may have some drooling. It's really important to note that they will have normal sensation. This is a functional motor issue. This is not a lack of sensation. If there is a lack of sensation, you must presume this is a stroke. Again, they may be a little bit painful even in the external auditory canal. They actually get hyperacusis, and they might actually be sensitive to noises, but also with this eye, it's going to become dry. They may have some impairment with their lacrimation. So how do we diagnose this? Facial nerve palsy is classically diagnosed based on clinical evaluation. So there's no specific diagnostic tests. It can be distinguished from a central facial nerve lesion, so a hemispheric stroke, which is most important to do. And that's going to be causing weakness, usually of the lower face. So strokes generally spare the forehead muscle. So that's kind of what's going to clue you in that this is Bell palsy. Central lesions, patients usually can furrow their brow, in which Bell palsy patients cannot. And generally speaking, strokes with the facial drooping don't affect the ability to close the eye. So there's some really important points. So this is based on clinical suspicion. All patients should undergo a chest x-ray and a CT chest, as well as an ACE level, because this may lead to the diagnosis of the major underlying cause, which is sarcoidosis. Viral titers are generally not helpful. It's not going to change their outcome or change your management. Do consider diabetes. You can run an A1C. If you're in an area that is known to have Lyme disease and it's that time of year, definitely keep that in consideration. Of course, get an MRI if this is a gradual onset, this weakness. You definitely don't want to miss this stroke, okay? Again, central lesions tend to spare the ability to furrow the brow and close the eyes. Do get a contrast enhanced MRI if you can, because this will help you to find schwannomas or tumors. And of course, if you are not in an area that has MRI, do consider CT of the brain with contrast if possible to rule out a stroke. Treatment is supportive for the most part. We want to protect the cornea, use natural tears or saline. That's super cheap. At night, if it is severe, have them taping or patching or wearing eye masks to, again, protect those eyes so they don't develop an abrasion or an ulceration. Very rarely, and I don't think I've ever seen this done, tarsorrhaphy is required, and that's where they actually surgically close the eyelid, temporarily, of course. Corticosteroids, they have been shown to improve the time to recovery and improve the chances of complete recovery, but this is best done if given within the first 48 hours of symptom onset. Again, first 48 hours by the book. I may consider this if somebody came in a little bit after that. Prednisone is generally what you'll use. It'll be a long taper, so a 2-week taper. And then, of course, you need to watch for comorbid conditions such as diabetes or gastritis. Make sure you're treating that. Antivirals, but the data actually suggests that there's no benefit for it, but it's very commonly done. Corticosteroids, benefit. Antivirals, no benefit. So that wraps up our lecture. Key points from especially pointed out by the Merck manual that in facial nerve palsy, people cannot move the upper and lower part of their face. That helps to distinguish it from a stroke. There is evidence that herpes viruses are the most common culprit. The diagnosis is clinical, but if you have any suspicion that this could be a stroke, go ahead and get that MRI if possible. And again, given early, corticosteroids are helpful. Antivirals probably don't provide benefit, but they're fairly benign, and it's a commonly done practice. Have a great day.